Assalamu alaikum and good evening to you all. So we'll discuss today on approach to a patient with dyspnea. It is a case-based discussion, and at first we'll discuss some cases, and then we'll discuss about the approach to a patient with presented with the dyspnea. এখন আমাদের কেস যদি 1 দেখি যে 72-year-old woman was admitted to hospital because of a few days history of progressive shortness of breath. এখানে 72 years old woman, she presented with shortness of breath. She had associated fever but no cough sputum production. এখানে shortness of breath আছে এবং fever আছে. Her medical history included rheumatoid arthritis for which she had been taking methotrexate for the past 12 years. তাহলে এখানে পেশেন্টে মেথোট্রেক্সেট নিচ্ছে। আমরা জানি ডিএমএ আরডি বলে ডিজিজ মডিফাইড অ্যান্টি রিউমেটিক ড্রাগ। এটা আমরা রিউমেটয়েড আর্থ্রাইটিসে ব্যবহার করি এবং এই ড্রাগ সে 12 বছর ধরে পাচ্ছে। এবং আমরা যদি এইটুকু একটা জানি যে কমপ্লিকেশনস অফ টেকিং মেথোট্রেক্সেট ফর এ লং টাইম, এটা যদি আমরা জানি যে দেয়ার মে বি পালমোনারি ফাইব্রোসিস, দেয়ার মে বি হেপাটিক ফাইব্রোসিস, এটা একটা কমপ্লিকেশন। সুতরাং দিস পেশেন্ট as present with a history of progressive shortness of breath and she had associated fever. এখন এই ক্ষেত্রে আমরা একটা করতে পারি যে this may be a complication of the methotrexate. একটা জিনিস এটা হতে পারে যে পালমোনারি ফাইব্রোসিস দিয়ে আমার শর্টনেস অফ ব্রেথ হচ্ছে, অথবা একটা জিনিস হতে পারে সেটা হলো যে এই রোগীর মেথোট্রেক্সেট পাচ্ছে, এটা ইমিউনোসাপ্রেসিভ ড্রাগ, সুতরাং ইমিউনিটি কম হয়ে অনেক সময় দেখা যায় যে আমাদের পালমোনারি ইনফেকশন হতে পারে। পালমোনারি যদিও পেশেন্টের কোনো কফ বা স্পুটামের প্রোডাকশন হিস্ট্রি নাই। তার মানে এইটা থেকে আমাদের লার্নিং কি? লার্নিংটা হলো যে একটা পেশেন্ট যখন শর্টনেস অফ ব্রেথ নিয়ে প্রেজেন্ট করে, আমাদের একটা হিস্ট্রি গুরুত্বপূর্ণ যে দিস টেকিং অফ দ্য হিস্ট্রি অফ এনি ড্রাগ ফর লং পিরিয়ড লাইক মেথোট্রেক্সেট usually which is used in the case of rheumatoid arthritis. এই জিনিসটুকু আমাদেরকে অনেক সময় হিস্ট্রিতে নিতে হবে, কেননা this pulmonary fibrosis is a important cause of shortness of breath for the prolonged period. আচ্ছা, যদি আমরা একটা কেস ধরি যে 45 years old heavy smoker present with increased dyspnea and persistent cough. এখানে যে হেভি স্মোকার একটা মোটামুটি ক্লু দিচ্ছে, সাথে পেশেন্ট is presenting with dyspnea and persistent cough. He had been working as craftsman for 35 years with a history of exposure to cement dust. এখানে যেমন একটা জিনিস, সিমেন্ট ডাস্টে তার is a history of exposure to cement dust for as long as 35 years. তাহলে সেক্ষেত্রে but no birds or other animals, fungi or other organic fine particles. He didn't report weight loss, sweat, or fever. On examination, he had normal vital signs, was comfortable at rest. Extremity showed considerable clubbing of fingers and toes. এখানে আমার clubbing finger আছে। আমরা জানি ILD বলে interstitial lung disease, যেটাতে আমাদের clubbing finger থাকে এবং যেখানে একটা exposure যে মানে long period of exposure to cement dust. It is long exposure to the cement dust may lead to the development of the ILD বা আমাদের লাং ডিজিজ, যেটা আমাদের প্রলং পিরিয়ড ধরে এটা হতে পারে। চেস্ট এক্সামিনেশন রিভিল ফাইন এক্সপিরেটরি বেসাল ক্র্যাকেলস, সেটা আমাদের সাজেস্টিভ অফ ILD। চেস্ট রেডিওগ্রাফ শোড রেটিকুলার নোডুল ইন বোথ লাং ফিল্ড, সেটা তো আমাদের সাজেস্টিভ। এবং HRCT শোড ডিফিউজ গ্রাউন্ড গ্লাস অপাসিটি predominantly involving the lung bridges or subpleural fibrosis. Pulmonary function test showed a moderate restriction, a moderate to severe diffusion abnormality. তাহলে আমাদের এই যে ইন্টারস্টিশিয়াল লাং ডিজিজ যেটা বলে ILD এর নিয়ে প্রেজেন্ট করতে পারে, সেক্ষেত্রে আমাদেরকে ডিটেলস হিস্ট্রি নিতে হবে। যে বিশেষ করে এক্সপোজার হিস্ট্রি, যেমন এখানে সিমেন্ট ডাস্ট যেমন একটা ইম্পর্টেন্ট, তেমনি এক্সপোজার টু দ্য বার্ডস অর আদার অ্যানিমেলস, অথবা এক্সপোজার টু দ্য এনি ফাঙ্গাস আদার অর্গানিক ফাইন পার্টিকেলস, এই হিস্ট্রিটা এটা গুরুত্বপূর্ণ। তার মানে এখানে আমাদের শর্টনেস অফ ব্রেথ নিয়ে যদি পেশেন্ট প্রেজেন্ট করে, এই জিনিসটুকু ইম্পর্টেন্ট। ফার্স্টে আমরা একটা ড্রাগের হিস্ট্রি দেখলাম, সেকেন্ডলি আমরা একটা দেখলাম যে হলো যে ইন্টারস্টিশিয়াল লাং ডিজিজ, যেখানে আমরা ইন্টারস্টিশিয়াল লাং ডিজিজ যেখানে prolonged exposure to the cement dust. It's another case A 76-year-old man presented with severe exertion dyspnea. He suffered from mild chronic obstructive pulmonary disease, congestive cardiac failure, and seropositive myasthenia gravis. Clinical examination of his chest and heart were unremarkable, but he had speech dyspnea and was unable to count 20 in a single breath. There was a severe shortness of breath actually. First degree sniff nasal respiratory measurement fell from 55 to 35 centimeter water, and FBC fell from 3.4 to 2.4 liter. A diagnosis of myasthenia crisis was carried out. A treatment with non-invasive ventilation. Intravenous immunoglobulin, high dose alprazolam was initially the patient responded with. তার মানে এখানে আমরা একটা জিনিস দেখতেছি যে আমরা পরবর্তীতে আমরা আসবো যদি এই পেশেন্ট ইফ প্রেজেন্টেড শর্টনেস অফ ব্রেথ, তখন এখন এই শর্টনেস অফ ব্রেথের জন্য আসলে আমাদের যে যে স্ট্রাকচারস আর কি আসলে আমাদের রেসপিরেশনের জন্য বা ব্রিদিং এর জন্য ইনভলভড, যেমন আমাদের ডায়াফ্রাম আছে, চেস্ট ওয়াল আছে, তারপরে ফুসফুস আছে, ট্রাকিয়া আছে। তাহলে এখন এই যে ব্রঙ্কিয়াল ট্রি সাথে সাথে চারিপাশে প্লুরা এবং আমাদের যে চেস্ট ওয়াল এবং আমাদের ডায়াফ্রাম, এখন এখানে আসলে যে কোনো ধরনের যদি প্যাথোলজি হয় সেই প্যাথোলজিতে পেশেন্ট মে ডেভেলপ শর্টনেস অফ ব্রেথ। এখানে মায়াস্থেনিয়া গ্র্যাভিস যেখানে আমাদের হলো মাসেল ইনভলভমেন্ট হয়েছে, স্পেশালি চেস্ট ওয়াল ইনভলভমেন্ট, সেক্ষেত্রেও কিন্তু আমাদের এই ক্ষেত্রে পেশেন্ট মে প্রেজেন্ট উইথ শর্টনেস অফ ব্রেথ if he or she is suffering from myasthenia gravis, and that may involve the chest wall muscles especially, and that lead to the actually paralysis type of disability, and that may lead to the development of the shortness of breath actually. তাহলে এখানেও ক্ষেত্রে একটা হিস্ট্রি আমাদের ওটাও একটা মনে রাখার বিষয় যে আমাদের চেস্ট ওয়াল প্যাথোলজি আমাদের মনে রাখতে হবে। আমরা যখন অ্যাপ্রোচটা পড়বো আরো সামনে যেতে আসবে তখনও কিন্তু আমরা এটা আলোচনা করবো যে আসলে কোন কোন জিনিসটাকে বা কোন কোন সিস্টেম বা কোন কোন আসলে অর্গান আসলে আমাদের খেয়াল রাখতে হবে যে এই পেশেন্ট প্রেজেন্টেড শর্টনেস অফ ব্রেথ। This is another case, a 48-year-old male patient present during the day for an urgent consultation. For over 10 weeks, he had a history of high-grade fever. সেখানে patient actually আমাদের যাচ্ছে যে fever, cough with mucopollulant expectoration, shortness of breath, with right-sided chest pain, weight loss more than 10% and night sweats. Gel examination showed a thin body build, pale skin, extreme dyspnea with oxygen saturation of 77%, and examination of the chest revealed air and fluid in the pleural space in the right side of the body. All the symptoms were checked and were clinically normal. A posterior anterior chest radiograph was pumped out, showed an air fluid level in the right hemithorax, a minimum shift of the mediastinum towards the left. তার মানে এখানে যদি আমরা দেখতেছি যে পেশেন্টের হাই গ্রেড ফিভার আছে, কফ আছে, মিউকোপোলুলেন্ট এক্সপেক্টোরেশন আছে, so this patient has definitely some kind of infections, especially involving their lungs or pleura, এবং এখানে pleural effusion পর্যন্ত আমরা দেখতেছি। তার মানে the patient may have pneumonia or post-pneumatic maybe pleural effusion or pleural involvement. So this patient have shortness of breath and oxygen saturation fall to near about 77%. So pneumonic consideration or pleural effusion may be a cause of the shortness of breath, এবং সেক্ষেত্রে we have to find out the underlying causes that may lead to the pulmonary consolidation or pulmonary pleural effusion or pneumonic consolidation. So we have to find out cause. In that cases, patient may have tuberculosis or may have another type of bacterial or infections that may involve the lungs. This is another case. A 66-year-old female presented to an outside hospital with increasing shortness of breath and cough. She complained of an unproductive cough for approximately 6 weeks. She denied hemoptysis but complained of a low-grade fever. So this patient is suffering from low-grade fever. Though she had no history of hemoptysis, over this time she became progressively more shortness of breath. So her shortness of breath is progressively gradually increasing in nature. At the time of presentation, she was able to only walk 100 meters before she had to stop due to dyspnea. So her shortness of breath, that is her pulmonary involvement is so severe that restricts her movement, and so she had to stop due to dyspnea even before completing the 100 meters walking. Her past medical history included obesity, gastroesophageal reflux disease, peripheral vascular disease, hypertension, and type 2 diabetes mellitus. So he has a lot of comorbidities, and that may lead to the development of this complications or this type of disability or disease to this patient. Lateral view on the chest extremity left upper lobe consolidation. So this patient has upper lobe consolidation. So it may be due to, as this patient is suffering from low-grade fever, approximately for the 6 weeks, as well as patient has obesity, GERD, and peripheral vascular disease, as well as hypertension and type 2 diabetes. So we know that type 2 diabetes is immunosuppressive or immunocompromised disease that may lead to the flare-up, lead to the development of the flare-up of tuberculosis in a patient. So this patient may have tuberculosis. So even this patient also may have pulmonary pathology like pulmonary tumor or pulmonary malignancy that may lead to the development of the left upper lobe consolidation with endobronchial lesion in the left upper lobe bronchus. So this may be a case of tuberculosis, or this may consolidation. The cause of this patient consolidation may be tuberculosis, they may be pneumonia, or this patient may have underlying bronchogenic carcinoma that may lead to the development of the fever or consolidation of the upper lobe. So this is another case, Mr. X, 60 years old, please and gentlemen, admitted in CSU of the in a hospital for respiratory distress, along with waiting for 2 hours. He had also history of exertional dyspnea for the 4 days. He is diabetic, hypertensive, and alcoholic. So this patient is also diabetes and hypertensive. On examination, his pulse is 104 per minute, so he is tachycardic, BP 120 nanomolar mercury, respiratory rate 20 per minute. And her examination showed there was a pansystolic murmur over the tricuspid area with increased with the acceleration of pulmonary component of the second heart sound. Hugo ratio, sinus tachycardia with S1Q3T3, electro ECG showed test revealed cardiomegaly, 2D transverse echocardiogram showed a lateral right side of the heart with a 5.6 centimeter and 1% mass in the right pulmonary artery. CT pulmonary angiogram found pulmonary embolism involving the right pulmonary artery, most of the segmental branches. He underwent duplex scan of the deep venous system of the both lower limbs, which was found to be deep venous thrombosis in the left pulmonary vein. So when considering a patient suffering from shortness of breath, so we should keep in mind that this patient may have any pathology, any deadly pathology like pulmonary embolism involving the pulmonary artery, and this pulmonary embolism may be embolized from the deep vein thrombosis. So we have to search for any causes of deep vein thrombosis. Even nowadays, if a patient suffering from COVID-19, he or she may have this type of pulmonary embolism or pulmonary thrombosis that may lead to the development of this type of shortness of breath. Eventually, this patient may have heart failure, as well as this patient may have sudden cardiac death due to hypoxemic injury or hypoxemia. So when you considering the a patient suffering from shortness of breath, this is the anatomy of the respiratory tract is important to know something about. So if any pathology involving the respiratory tract, like from the sinuses, pharynx, trachea to the lung tissue alveoli, if there is any pathology involving these areas, that may lead to the shortness of breath. And when you consider the physiology of breathing, I have already discussed that the structures involving the breathing, like pulmonary or bronchial tree or bronchial breath, that is from the nose to the alveoli with lungs, and this is chest wall, pleura, even the diaphragm. And all this factor may lead to the development of the shortness of breath. If there is any involvement of any parts of these 4 organs involved, that may lead to the development of the difficulty breathing. So we have to consider when a patient having shortness of breath. So we have to keep in mind that the pathology may lies in any of the 4 structures like bronchial tree, that is from the nose to the alveoli. The pathology may in the chest wall, that is ribs or muscles, or is even in the skin, and this patient may have pathology in the diaphragm, or this patient may have the pathology in the pleura also. So we have to keep these 4 structures, especially that involves to the shortness of even. And even out of these 4 structures, even if a patient has hypoxemia, or due to any cause, or this patient may have hypercapnia, that is increased carbon dioxide level in the blood, or there is any nervous system disturbance, or if this patient has even psychogenic any type of pathology that may lead to the development of shortness of breath, outside these 4 structures that involve in the breathing, physiology of breathing. So if we look into the definition of dyspnea, especially, or shortness of breath or difficulty breathing. So dyspnea is the sensation of breathlessness or inadequate breathing, and is the most common complaint of patients with cardiopulmonary disease. So dyspnea common complaint is the shortness of breath, so or defined as the uncomfortable breathing, or this is the awkward breathing. It's also called the dyspnea. So dyspnea on exertion is excessive or abnormal shortness of breath on exertion. So it can be defined in other ways, that dyspnea is a subjective experience of breathing discomfort that is comprised of polyply distinct sensations that vary in intensity. They experience rest from interaction among multiple physiological, psychological, social, environmental factors, and it may induce secondary physiological and behavioral response. So there is a lot of causes, the underlying is the dyspnea. There's a lot of factors. There may be some multiple physiological factors or psychological factors, even social factors and environmental factors that may incite the development of the dyspnea. For another type of definition. So dyspnea may be defined in other ways, like is it defined as the unpleasant subjective awareness of sensation of breathing, or it can also be defined as the uncomfortable need to breathe. So there is dyspnea is the subjective sensation of breathlessness. So how it can be classified? So it can be classified by NOIC classification or MMRC classification. So in a YC classification, like class 1 and class 2, class 3, and class 4. Class 1 is the disease present but no dyspnea, or dyspnea only on heavy exercise. So class 1 dyspnea is this patient may not experience any type of shortness of breath, or patient may experience shortness of breath only he or she have heavy exertion or too much exertion. Class 2 is the patient experience dyspnea on moderate exertion. Class 3 is the dyspnea on the mild exertion. And class 4 is the patient experience shortness of breath or dyspnea even at the rest. This is the class 4 here, and this classification is according to the New York Heart Association classification in OISA, and this is the MMRC classification. Here is the grade 0, grade 1, and grade 2. Grade 0 breathlessness with the strenuous exercise. After that is when patient has got severe shortness, patient got shortness of breath in the severe exercise, then it is grade 0, and grade 1 is a patient developed shortness of breath when hurrying on level 1 ground or walking up a slight hill. That is সিঁড়িতে উঠতে গেলে অথবা যদি কোনো পাহাড়ের উপরে উঠতে গেলে যখন শ্বাসকষ্ট হয়, এটা আমরা গ্রেড 1 বলতেছি। আর গ্রেড 2 হলো 1 level ground walk slower than people of the same age because of the breathlessness have to stop for a breath when walking at my own pace on the level. অর্থাৎ গ্রেড 2 বলতেছে যে আমরা যখন নর্মালি যে গ্রাউন্ডে হাঁটি, কোনো স্লোপে না বা উপরে ওঠা না, নর্মাল যে গ্রাউন্ডে হাঁটি, সেটা যদি এরকম হয় যে আমাদের বয়সের যে একটা মানুষের চেয়ে আমরা স্লো হাঁটতে আমি বাধ্য হই, যে শ্বাসকষ্ট যদি এর চেয়ে বেশি জোরে হাঁটি বা ওদের সাথে তাল মিলে হাঁটতে চাই তাহলে আমার শ্বাসকষ্ট হয়। অথবা যদি এরকম হয় যে আমাকে হাঁটতে গেলে শ্বাসকষ্টের জন্য থামতে হয়, তাহলে সেটাকে আমরা বলতেছি grade 2 shortness of breath or dyspnea. So when treating a patient with dyspnea, then we have to consider actually the duration of the dyspnea. Patient may have acute dyspnea or patient may have chronic dyspnea. So when patient had acute dyspnea, so we have to keep some differential diagnosis in our mind that patient may have pulmonary edema, patient may have asthma, chest wall injury, pneumothorax, pulmonary embolism, pneumonia, acute respiratory distress syndrome, pleural effusion, or pulmonary hemorrhage. Actually, these are the cause of the acute dyspnea. When patient present with chronic or progressive dyspnea, in that cases, we have some differential diagnosis like COPD, congestive heart failure, interstitial fibrosis, asthma, effusion, thromboembolic disorder, pulmonary vascular disease, psychogenic dyspnea. Even patient, if patient have anemia, there is hemoglobin percent less than 7. Even this type of severe anemia can lead to the sensation of the shortness of breath to a patient. Tracheal stenosis and hypersensory disorder. And these are usually the cause of the chronic or progressive dyspnea. So when a patient presents with shortness of breath, so we have to keep in mind that we have to have some organs that may lead to the development of the that is responsible for the development of the shortness of breath. In that cases, at first we have to consider there is a heart or cardiac cause. If the patient has got some valvular heart disease or ischemic heart disease or left ventricular failure due to any causes that may lead to the development of the shortness of breath. So you have to keep in mind that some causes of cardiac cause that may lead to the development of the shortness of breath. And there may be some pulmonary causes like airway and interstitial disease. Airway disease, that is any obstructive pathology that may involve the tracheal tree or the bronchial tree that may lead to the development of the shortness of breath, or if there is a interstitial space disease, or that is the disease that involves the alveoli also, then that can causes the shortness of breath. If there is some anatomical structures like muscles or pleura or chest wall, that may lead to the development of the shortness of breath. If there is a trauma, and that may lead to the development of pneumothorax or hemothorax, that causes the shortness of breath. And there are some other causes like thyrotoxicosis, ketoacidosis, aspirin poisoning, anemia, and psychogenic. Sure, this is the last but not the least, is an important cause of the shortness of breath or dyspnea, especially in a young female, that causes the shortness of breath. So these are the actually organ that is responsible for the shortness of breath in a patient. So we have to keep this organ like heart, lungs, structures of the chest wall, trauma, and some other causes like thyroid, thyrotoxicosis, or ketoacidosis, or aspirin poisoning, anemia, or psychogenic, that may causes the shortness of breath. So when considering the patient presenting with shortness of breath, so we have to have some differential diagnosis considering the organ involvement especially. So we have to keep in mind that there is maybe cardiac involvement, there may be pulmonary involvement, there may be mixed both cardiac and pulmonary involvement, and even there may be non-cardiac, non-pulmonary involvement like psychogenic cause, or there may be aspirin poisoning that may causes the shortness of breath. And when considering pulmonary etiology, actually these are the etiology, or this is the pathology that can causes the shortness of breath, like COPD, asthma, bronchial asthma, restricted lung disorders, and then pneumothorax, pneumonia, and some hereditary lung disorder. And these are the actually pulmonary causes of shortness of breath. There may be some cardiac etiology like congestive heart failure, coronary artery disease, recent or past history of myocardial infarctions, cardiomyopathy, arrhythmias, pericarditis, that is pericardial involvement, left ventricular hypertrophy, or valvular involvement, vascular valvular dysfunction like mitral valvular, aortic valvular, or tricuspid valvular, even pulmonary valvular. Any pathology, stenotic or regurgitant pathology, that may lead to the development of the shortness of breath. There may be mixed cardiac and pulmonary etiology like COPD, with pulmonary hypertension or called pulmonary, that is called, or patient have deconditioning or patient chronic pulmonary embolism or pleural effusion. And these are the mixed cardiac and pulmonary causes that can cause a shortness of breath. And with the cardiac or pulmonary involvement, even patient may have shortness of breath. So what are the causes? There are some metabolic conditions like acidosis. We have already discussed that aspirin poisoning may lead to the development of the shortness of breath or acidosis. Or there is a chest trauma to the chest, that is pain may cause shortness of breath, or trauma may cause shortness of breath. Or there is some chemical exposure, or there may be some neuromuscular disorder like we have already discussed, myasthenia gravis, that can cause shortness of breath. Even patient may have functional, that is psychogenic, some psychogenic cause, or hyperventilation syndrome, or anxiety, even panic attack, that may lead to the that may cause the shortness of breath also. So to memorize easily, we have 6 P's of dyspnea, that is 6 P causes of dyspnea, like 1 P pulmonary, that is bronchial constriction, 2nd P is possible foreign body, 3rd P is pulmonary embolism, 4th P is the pneumonia, 5th P pump failure, that is heart failure, and 6th P is pneumothorax. And these 6 important causes, that is that are those are easy to memorize as a cause of the dyspnea. So when we classify dyspnea, that may be this is the way that how we can classify the dyspnea. That is cerebral dyspnea, that is central causes like that involve the respiratory center or cortex function, especially these are the causes like acidosis, especially acidotic cause that causes the cerebral dyspnea. There's especially lung dyspnea, that is lung causes like any pathology involving the lung or pleura, where the patient may have cardiac dyspnea. So the patient may have valvular heart disease, or patient may have ischemic heart disease that can causes heart failure and causes cardiac dyspnea, or patient may have hematemic dyspnea, that this patient has low hemoglobin level in the blood. There is anemia that can causes the hematemic dyspnea, or even acidosis can cause this type of dyspnea. So acidosis even can cause the cerebral dyspnea also. So we have already discussed the different types of underlying causes of cardiac cardiac underlying causes that cause dyspnea. We have already discussed the respiratory causes. We have hematological, abdominal, metabolic, psychogenic, neurological, physiological causes. Even we have discussed some uncommon causes also. So what are the red flags of serious form dyspnea? That is, আমরা কিভাবে বুঝবো যে একটা পেশেন্টের শ্বাসকষ্ট হচ্ছে কিন্তু এটা ইমার্জেন্সি খুব এটা হাসপাতালে ভর্তি লাগবে immediately, বা even this patient may need ICU management also. সেটা আমরা কিভাবে বুঝবো? A patient suffering from dyspnea, but he or she developed hypotension, or his or her heart respiratory rate is more than 40 beats per minute, and he or she has altered mental status, or he or she has hypoxia, that is significant oxygen saturation level fall করছে, যদি fall করে, if patient develops cyanosis, this patient have a stridor, if have breathing effort without air movement, and there is no air in or there is no air out, that is the limited amount of air in and out with patient have breathing effort. In that cases, this is actually red flags. Tracheal deviation with unilateral breath sounds and unstable arrhythmia. Patient may have BT or BF type of arrhythmia or fatal arrhythmia that can causes the sudden, even patient have sudden cardiac death also from this cause. So these are the red flags of serious form of dyspnea. So when considering shortness of breath, and if a patient present with emergency presentation, if patient have emergency presentation, or patient presented in the emergency department, so what are the things we should consider? We should consider if a patient has got any stridor, if patient has got a stridor, so in that cases you should think that patient may have upper obstruction like foreign body or tumor, acute epiglottitis, anaphylaxis, and trauma like laryngeal fracture. If when we ausculted the chest, if we found the crepitations, then a patient may have heart failure or pneumonic constellation or bronchiectasis, or patient may have fibrosis like interstitial lung disease. And when we see that the patient has wheezing, so in that cases, we may consider this patient may have bronchial asthma, COPD, even heart failure can cause wheezing or anaphylactic reactions, and that causes the bronchoconstriction that may lead to the development of the shortness of breath also. If we found that the patient chest is clear, but the patient has got shortness of breath, so what we should think? In that cases, we should think that patient may have pulmonary embolism, hyperventilation, metabolic acidosis, that is diabetic ketoacidosis. Patient may have shock, or patient may have some central causes that can cause the, even in that cases, patient has shortness of breath, but there is no findings in the chest, no crepitations, no wheeze, no stridor, or in that cases. And in some other cases like pneumothorax, if patient has got pain and increased resonance on auscultation and pleural effusion, if we on percussion, or if we feel that the patient has got stenoid illness, in that cases, we may think this patient have pleural effusion. And when considering the speediness of the occurring of the shortness of breath, that is, we should consider if the patient has got acute onset or subacute onset or chronic onset. If patient has got rapid onset or acute onset, that we should think about the patient may have foreign body, patient may have pneumothorax, patient may have acute asthma, patient may have pulmonary embolism, even patient may have acute pulmonary edema. These are the differential diagnosis. If the patient has acute presentation, we have to think of this as several causes. If patient presentation has subacute causes, in that cases, patient may have asthma or parenchymal disease like alveolitis, effusions, pneumonia, or interstitial lung disease. If the patient has chronic involvement, that patient may be COPD or chronic parenchymal lung disease like interstitial lung disease, or non-respiratory causes, patient may have cardiac failure or anemia. And these are the causes of chronic shortness of breath of the patient. When a patient came to a hospital, so considering his severity, we can triage this patient in a triage center, and so we have may select this patient where the patient should be treated. In that cases, we have 3 zones like green zone, yellow zone, and red zone. So if a patient has acute exertion of the bronchial asthma and the severity is mild to moderate or hyperventilation able to walk, in that case, the patient should be treated in the green zone. And if a patient dyspnea is less than 25 breaths per minute and dyspnea with saturation of more than 95% and respiratory rate is 20 to 25 per minute, or a patient is hyperventilation and unable to walk, in that case, the patient should be treated in the yellow zone. And if the patient has got dyspnea of saturation less than 95% of and respiratory rate is 25 per beats per minute or more, and patient with airway compromise like gasping, severe maxillofacial injuries, or if a patient is comatose patient, that is patient is in coma, or patient has got severe bronchial asthma or COPD, and his or her saturation is falling, in that case, a patient should be managed in the red zone. So depending on the severity of the patient with shortness of breath, a patient should be treated in the respective zone. And this is the actually pathophysiology of a shortness of breath. In that cases, we have already discussed the pathology may lies in the brain or spinal cord, that is central cause, or patient may have chest wall involvement, or patient may have diaphragmatic involvement, or patient may have pleural involvement or pulmonary involvement, or patient may have cardiac causes also. So we have to consider these mechanical breathing abnormalities, these different causes, perception of these two by the central nervous system, and some chemoreceptor stimulation like afferent system involvement. In that cases, if patient developed hypoxemia or hypercapnia, or patient have acidosis, in that cases the central chemoreceptors or some peripheral chemoreceptor may be stimulated, and this afferent system is stimulated or activated, and and patient and this afferent, by this afferent pathway, the sensation of the shortness of brain may be transferred to the brain also. So there are some receptors that may involve in the mechanism of dyspnea. We already known in the physiology that there are a lot of receptors like J receptors, stress receptors, chemoreceptors, and receptors in the respiratory muscle that may be activated or then may be stimulated. And this stimulation is usually carried by the afferent nervous system, afferent pathways to the central nervous system, and that may lead give to the sensation of the shortness of breath of the patient. And this is the algorithm for the inputs in the dyspnea production. There is actually a lot of the receptor involvement like mechanoreceptor, chemoreceptors, or metabolic receptors. And these receptors is stimulated, and this is it transfers the sensation transfer to the sensory cortex. And from the there may be also the some respiratory center involvement, respiratory drive that stimulates the motor cortex, and also the involvement of the ventricular muscles also. So these are actually a complex process and that involve a lot of structures that lead to the sensation of the dyspnea actually. Pathophysiology already we have discussed in several ways. And when patient present with dyspnea, so these are the initial assessment of patient with dyspnea. When a patient present with dyspnea, so at first we have to assess the airway patency and listen to the lungs. That is very, very important. Observe breathing pattern, including use of accessory muscles. If patient uses accessory muscles, that indicates this patient has got severe shortness of breath. So this patient should be treated in the red zone actually. Monitor cardiac rhythm. We know that if the patient has fatal cardiac rhythm, like ventricular tachycardia or ventricular fibrillation, in that case, actually patient should be treated with the red zone also, or this patient should be taken seriously. Measure vital signs and pulse oximetry. By vital signs and pulse oximetry, we can also triage the patient and select the patient where patient should be treated actually. Obtain any history of cardiac or pulmonary disease or trauma, and evaluate the mental status. If the patient mental status is oriented, but if patient is disoriented, so these are the important the sign, and that this patient should be treated in the red zone actually. So when during assessment of a patient with dyspnea, so we have to take the history of onset, the position of the timing, severity, any precipitating or relieving factors, or any associated symptoms with the dyspnea that may help to differentiate different causes of shortness of breath, and we may that may help to reach a specific diagnosis of the shortness of breath. So this differential diagnosis in acute shortness of breath. There may be some cardiac causes like congestive heart failure, coronary disease, arrhythmia, pericarditis, acute mitral infarction, arrhythmia. There may be some pulmonary causes like chronic obstructive pulmonary disease, asthma, pneumonia, pneumothorax, pulmonary embolism, pleural effusion, metastatic disease, pulmonary edema, gastroesophageal reflux disease with aspiration and restricted lung disease. This patient may have some psychogenic causes like panic attacks, hyperventilation syndrome, pain and anxiety, upper air obstruction like peak glottitis, foreign body infection, croup, Epstein-Barr virus infection. The patient may have some endocrine causes like metabolic acidosis. There may be some medication that can cause the acidosis. Also, there may be subcental causes like neuromuscular disorder, pain, aspirin overdose. Even as there may be some causes of shortness of breath in the pediatric population like bronchiolitis, croup, epiglottitis, foreign body aspiration. Even myocarditis is an important cause of shortness of breath actually in the pediatric age group. So what are the investigations we should do to differentiate, to reach a diagnosis of a cause of shortness of breath? So we have to do some chest radiographs, ECG, and scanning spirometry, echocardiography, pulmonary function test, ABG, even some standard exercise treadmill test, or some specific investigations, even biochemical investigations to see the heart failure, causes of heart failure, or the condition of the heart failure, also severity, to see the severity of the heart failure. these are the physical findings actually that can help us to differentiate the defined cause of shortness of breath. In a case of acute dyspnea, like if a patient has wheeze, pulsus, paradoxus, and accessory muscles use, in that cases, we have to keep in mind that the patient may have acute asthma, COPD, acute exertion. If the patient has wheezing, clubbing, barrel chest, and decreased bass sounds, in that cases, we should keep that the patient may have COPD exertion. If the patient has fever, crackles, increased fremitas, that may lead to the suspicion of the case of pneumonia. If the patient has edema, neck vein distension, S3 or S4 hepatojugular reflux, murmurs, rales, hypertension, and wheezing, then we should consider this patient may have congestive heart failure or pulmonary edema. If the patient has wheezing, friction rub, lower extremity swelling, and then that may suggest pulmonary embolism, absent bass sound, hyperresonance, that is the sign of pneumothorax. Instead of stridor, rhonchi, and retractions is present, that is the diagnostic of croup. Stridor, drooling, and fever gives the diagnosis of epiglottitis. Stridor, wheezing, persistent pneumonia indicates the patient may have foreign body aspiration, wheezing, flaring, intercostal interactions, apnea, and sighing that causes the bronchiolitis or hyperventilation sign. So actually, these are the signs that hints that give hints to some diagnosis also. And this is the algorithm if a patient presents with dyspnea, actually how we will proceed or approach the patient with dyspnea. At first, we have to take a detailed history. We have to have quality of sensation, timing, positional disposition, persistent or intermittent type of shortness of breath. We have to do physical examination like general appearance. To see the vital signs, we have to examine the chest, we have to do some cardiac examinations, and we have to also see the extremities if the patient has got any edema or sinuses or not. At this point, if the diagnosis is evident, if not evident enough, then we have to proceed to further investigation like chest X-ray to see the cardiac size, evidence of congestive heart failure, assess for hyperinflation. Even we have to see the features of consolidation or IL interstitial lung disease or pleural effusions. If the patient has low cardiac output of myocardial ischemia or pulmonary vascular disease, then we have to do ECG echocardiography, and we have to also pulmonary artery to see the pulmonary artery pressure also. We may have to do some biochemical tests like serum BNP level also. If the patient suspected respiratory pump or gastric abnormality, in that cases we may have to do some pulmonary function test, including the CT angiogram to see the any pulmonary artery involvement. That is, a patient may have pulmonary embolism also or pulmonary thrombosis. If the patient has suspected high cardiac output, in that cases we have to do some complete blood count, like to see the hemoglobin percent, to see the patient has got any anemia or patient has got hyperthyroidism, so thyroid function test should be done. So, so if a patient presents with shortness of breath, so we have to do the investigations we have already discussed, and now how the patient should be managed. In that cases, at first, patient should give first aid. If the patient got unconscious and shortness of breath or impaired consciousness, in that cases, call local emergency, and then check the airways or breathing and pulse. If necessary, begin CPR, cardiopulmonary resuscitation may be necessary, and loosens any tight clothing also. And for a first aid, we have to also help the person use any rest guard medication if the patient has got shortness of breath, and if he is using inhaler to relieve his or her shortness of breath. In that cases, patient should, we should help the patient to take his or her medications properly. So we have to also monitor the breathing and pulse. If the patient has got any wound and that bleeds, and if there is a air bubbles also, so there may be respiratory involvement. So in that cases, we have to manage accordingly. And bandages with sucking wound with plastic wrap, saline except for more one corner. And what we should not do. We should not do to give the person food or drink at the time. Do not move the person if there has been a chest or a injury, and it is absolutely necessary. Do not place a pillow under the person's head that can close the airway, and do not wait to see if the person's condition improves before getting medical help. Get help immediately, and patient should be transferred immediately. And these are some pharmacological treatment to aid the patient relief of the shortness of breath. These are some bronchodilators. Patient may need some steroids as patient, if the patient suffering from anxiety or psychogenic causes of ventilation, patient may need some anti-anxiety drugs. Even patient, if the patient has severe pain and that is the cause of the shortness of breath, so we have to give some medications that can relieve the pain of the person. And this is the paroxysmal nocturnal dyspnea. We have already we have already have this terminology, paroxysmal nocturnal dyspnea. So what is paroxysmal nocturnal dyspnea? The severe difficulty in breathing that awakens the patient from sleep and forces him to a sitting or standing position. আমরা সবাই জানি paroxysmal nocturnal dyspnea এটা হলো যাদের বেশ করে হার্ট ফেলিয়ার হচ্ছে বা ইম্পেনিং হার্ট ফেলিয়ার আছে, যারা সাধারণত দেখা যায় রাত্রেবেলা শোয়ার পরে মাঝরাতের দিকে শ্বাসকষ্ট ঘুম ভেঙে যাচ্ছে, আবার উঠে বসতেছে, বসার পরে সে জানলা টানলা খুলে দিচ্ছে, একটু হাঁটাহাঁটি করতেছে, তার শ্বাসকষ্ট কমতেছে। আবার যখন সে শুচ্ছে বা শুয়ে তার আবার হয়তো শ্বাসকষ্ট হচ্ছে। So actually heart failure is the cause of paroxysmal nocturnal dyspnea by PND. So what is the underlying mechanism of paroxysmal nocturnal dyspnea? If patient has interstitial or interalveolar pulmonary edema, that may be the secondary to the heart failure or ventricular failure. This symptom is 2 to 4 hours after sleeping. Patient arises from sleep, feeling shortness of breath, and symptoms ameliorated by sitting on the side of the bed and take out 15 to 30 minutes. Patienটের শ্বাসকষ্ট হলে patient উঠে বসে থাকলো এবং 15 থেকে 30 মিনিট পর শ্বাসকষ্ট ভালো হয়ে যায়। So cardiac dyspnea, আমরা already discussed left ventricular failure or valvular disease can cause cardiac dyspnea even if patient has Eisenmenger syndrome. So what is Eisenmenger syndrome? If patient has ASD, VSD or PDA and patient may develop pulmonary hypertension and there is the reversal of the shunt also. This is called Eisenmenger syndrome. So if a patient has if he or she has Eisenmenger syndrome, so this patient may have cyanosis and clubbing and shortness of breath also. Evaluation of the pregnant woman with dyspnea. So how will evaluate if a pregnant woman presented with dyspnea? So we have to look after for cough or wheezing present, or if there may physical dyspnea of pregnancy is not associated cough or wheezing. Acute cough is most commonly due to an acute respiratory tract infection and acute exertion of the underlying chronic pulmonary disease, pneumonia or pulmonary embolism. Cough that has been present longer than 3 weeks is either subacute or chronic. Common symptoms of asthma and cardiac disease with pulmonary venous hypertension. Evidence of airflow obstruction or pulmonary function testing supports the diagnosis of the asthma. So I think we have discussed the approach to a patient with shortness of breath properly, and I think তোমাদের মোটামুটি ভালোভাবে বুঝতে পারছো। তারপরে যদি আমরা সামারাইজ করতে চাই, সেটা হলো যে শর্টনেস অফ ব্রেথ নিয়ে যখন কোনো রোগী আসবে তখন কয়েকটা জিনিস আমাদের মাথায় শান্ত রাখতে হবে। কি কি রাখতে হবে? There may be a lot of causes or there may be a lot of differential diagnosis. বিভিন্ন স্ট্রাকচার বা বিভিন্ন অর্গান ইনভলভ হলে হতে পারে। সেক্ষেত্রে আমরা সহজভাবে যদি মনে রাখি, যেহেতু আমরা শ্বাস প্রশ্বাস যেটা নিই সেটার জন্য সবচেয়ে ইম্পর্টেন্ট যেটা অর্গান সেটা হলো ফুসফুস, ট্রাকিয়া। সুতরাং এইখানে যে কোনো ধরনের প্যাথোলজি যদি হয় তাহলে আমাদের শর্টনেস অফ ব্রেথ হতে পারে, অথবা যদি প্লুরাল ইনভলভমেন্ট হয়, অথবা যদি ডায়াফ্রাম ইনভলভমেন্ট হয়, অথবা যদি চেস্ট ওয়ালে রিবস অথবা মাসেলস অথবা স্কিন ইনভলভমেন্ট হয়, দ্যাট মে লিড টু দ্য ডেভেলপ শর্টনেস অফ ব্রেথ। তারপর 8টা অর্গান হলো ইম্পর্টেন্ট, সেটা আমাদের হার্ট। হার্ট যদি কখনো ফেল করে, দ্যাট মে বি ডিউ টু ভালভুলার হার্ট ডিজিজ অর দ্যাট মে ইসকেমিক হার্ট ডিজিজ অর করোনারি ডিজিজ, যে কোনো কারণে, আর ইভেন মেবি কার্ডিওমায়োপ্যাথি, পেশেন্টের হলো যদি কার্ডিয়াক আউটপুট কমে যায়, তো সেক্ষেত্রে দিস পেশেন্ট মে হ্যাভ শর্টনেস অফ ব্রেথ ডিউ টু পালমোনারি এডিমা অর ইন্টারস্টিশিয়াল এডিমা অ্যাকচুয়ালি। এছাড়া আমাদের যেটা আছে, দেয়ার মে বি সাম সাইকোজেনিক কজ, সাইকোজেনিক কজের স্পেশালি ইন ইয়ং ফিমেলদের ক্ষেত্রে a patient may present with anxiety or panic attack or hyperventilation syndrome, আমাদের shortness of breath হতে পারে। অথবা আরেকটা জিনিসের মধ্যে there may be some central causes, এখানে আমাদের কোনো ট্রমা অথবা আমাদের অ্যাসিডোসিস or hypoxemia বা হাইপারক্যাপনিয়া, যেটা এগুলো সাধারণত হতে পারে। এছাড়া আমার যদি অ্যানিমিয়া হয়, বিশেষ করে অ্যানিমিয়া ইজ ইম্পর্টেন্ট কজ অফ অ্যাকচুয়ালি শর্টনেস অফ ব্রেথ। শর্টনেস অফ ব্রেথ থাকলেও আসলে সেক্ষেত্রে আমাদেরকে সামান্য যে হিমোগ্লোবিন পার্সেন্ট বা একদম কমপ্লিট ব্লাড কাউন্ট, এটাও আসলে আমাদের করা উচিত। আজকে এই পর্যন্ত, ইনশাল্লাহ নেক্সট কোনো একটা এতে দেখা হবে।